As ordered, move to me.
Good evening, everyone. I'm Sonojan at the University of Cincinnati, and I'd like to welcome you all to our combined hand-in-hand series that the American Association for Hand Surgery has done with the American Society of Reconstructive Microsurgery that is on burning bridges and upper extremity reconstruction. What do I do now? I'd like to introduce our moderator, Dr. Babak Safa from the Balki Clinic. Babak.
Great. Thanks so much, Sonu, and thanks to Ilya for helping organize this. Can you guys see my video feed or no?
But not currently.
Let's toggle back and forth here. There we go. Let's see. Well, I'm going to share my screen either way so we can at least get this going. I'm going to introduce our speakers for tonight. 1 second. All right. Okay, can everyone see the screen?
Yes.
Yes.
Okay, perfect. All right,
Yeah.
so welcome again to the combined AHS ASRM hand-in-hand webinar. This is on burning bridges and upper extremity reconstruction. What do I do now? This is a really important topic because in complex upper extremity reconstruction, oftentimes we find ourselves in a situation where a bridge has been burned either by ourselves or by someone else. And so it's difficult to know what to do, and it's more difficult to even carry it out. We have a great set of speakers tonight. Our first speaker will be Dr. Scott Levin, who needs no introduction. As we know, Dr. Levin is outgoing chair of the Department of Orthopedic Surgery at UPenn. He's a co-director of the Penn Nerve Center, also founder of the Penn Orthoplastic Limb Salvage Center, as well as the Paul B. Magnuson Professor of Bone and Joint Surgery and Professor of Plastic Surgery. I'm going to do all the intros first, and then we'll go to all the speakers. Our speaker following Dr. Levin is Dr. Chris Peterson, who also needs no introduction. He currently is chief of the Division of Plastic Surgery at Baylor. He's also professor of not only surgery, but also orthopedics and pediatrics. And he's the Sam Stahl Endowed Chair in Plastic Surgery. Next up, Dr. David Colin is the assistant professor of surgery and plastic surgery at Yale. He also is part of the Yale Limb Restoration and Limb Lengthening Program, and he is the acting fellowship director in hand and microsurgery at Yale. And next up, Dr. Stephanie Russo. She is a pediatric hand and peripheral nerve surgeon, and she co-directs the Brachial Plexus Treatment Center at Akron Children's Hospital. And she treats everything from brachial plexus injuries to spinal cord injuries, spasticity, and also congenital anomalies of the upper limb. And last but not least, Dr. Jeff Friedrich. He's professor of surgery in plastic surgery, orthopedics, and adjunct professor of urology at the University of Washington. He also directs the UW Plastic Surgery Residency, and he's the associate director of the University of Washington Hand Surgery Fellowship. So with that, Scott, go ahead and take it away.
Baba, can you hear me?
I can hear you.
Okay, sharing screen. Can you see this? Please say yes.
I don't see it yet.
End show. Let me get out of this. How about now? Can you see this?
I don't see it unless anybody
Can
else
somebody
can.
let me, maybe you have to let me share. I don't know if our technical moderator's there.
Ilya, can you make sure Dr. Levin can
Share
is
screen.
able to...
How about now?
Now, oh, there we go. Okay, perfect. That's it.
Okay, I have something in the middle, All right, let me move this out of the side here. So you can see me, right?
Yes, we're good to go.
Okay, so, first of all, I'm happy to be here. Thank you for inviting. This is not best case, best save from the ASRM, but burning bridges and upper extremity reconstruction. What do I do now? It's basically Babak and team and audience. What do I do now when I have a problem? So let's see here. I'm trying to advance. That's not working. Let me see here. Let me just go here. So let me set the stage. The big guy on the left is with the prosthetic is a guy I did a TMR on. He had a huge radial nerve neuroma. We have many NGOs that bring Ukrainian soldiers to us. This guy is like 6'10", 300 pounds of muscle, but had his arm blown off. And here he is with President Zelensky in Washington. We have every Tuesday here at Penn Medicine a virtual online consultation, maybe 4 days a week. Steve Kovac, myself, Saeed Azuri, and Jason Wink, and other plastic surgeons team up with our orthotrauma people, and we get online with our Ukrainian colleagues, and they show us, pretty bad upper and lower extremity and blast injuries, adults, children. What do you do? And they really didn't know much about flaps or reconstructive surgery until we put on, I think it was in 2022, a flap course in Heidelberg, and Gunter German, the past president, helped organize that. And Steve and I went over, and some of the German colleagues were there, and we taught the Ukrainian people basically pedicle flaps, but not microsurgery. And here are a couple of these guys in my clinic. And the young gal that's on the shot of the computer is a Ukrainian medical student who's spending a year here. So I want to recognize Andy Bowder and Steve Kovac, who've both been to Ukraine. And of course, we've supported this. So that was just the video transmission. They're talking about free fib. And I teed a case up with my advice for Steve and Andrew Bowder, who did that when they went over to Ukraine, but the soldiers come to us as well. Baba, can you hear me okay? I hope so.
Yes.
Yeah, we can
Okay,
hear you.
good. Yeah, okay, good. So this guy walked into my clinic, huge blast injury. And what you'll note here is the humeral head is just sort of auto-fused to the glenoid. But he has this huge defect, and this fixator has been on for like 9 months, and they have no idea what to do. And this is a little better shop. So the shoulder is ankylosed, and he sort of auto-fused. And I'm thinking, okay, I'll do a free fib, get this done, take this down, and give him an endoprosthesis. So an osteocutaneous fibula, and like an idiot, what I didn't realize is because his proximal humerus is ankylosed to his glenoid, his arm can't be abducted. So sort of a game day decision. Again, first strike against me. I thought about this case a lot, and I thought, okay, osteocutaneous fibula, I've done a lot of them. We've reported on it, but how am I going to get to his vessel? So I basically wound up doing an AV loop because I couldn't abduct to go end to side to his brachial. And so here's our saphenous vein harvested here. Nothing unique about this, but it was difficult sewing, down in the medial aspect of the arm with his arm couldn't be abducted. And so here we have the loop up. Hearing is believing, as we say. And you can see, there's inflow to the flap. Here's a nice skin paddle. We have this long plate here, and everything, looks pretty good. And, here we are again, just checking him and thinking, okay, we've done this before. No big deal. You always need skin. But if you look in the upper right here, this was sort of like skin graft over periosteum. And again, whenever you take a skin paddle for these, when I say you never have enough, we took a fair amount thinking it's going to be okay. And with edema, and everybody knows this, not that we came up short. This is inset. There was some redundancy, but the plate was sitting sort of right under this periosteal, not so great skin fin flap. And so here's the loop, here's the locking plate, and you can see this thing pulsing away. Okay, we're doing great. Everything's hooked up. We're going to the unit. Everything's fine. And, here we are. So here's the construct. Fibula, jammed up into this humeral head, a spring plate to obviate putting any screws in the fibula per se, and then a long neutralization plate and the skin paddles there. But I wouldn't say horrible, tenuous proximal coverage, but not great. So if you think that's the problem, you're wrong. So here we are at about 36 hours. The vein goes down. Here's the AV loop. We did a middle frame here. We had to come back, did a venous interposition distally to the antecubital fossa. Rather than going, I took the loop down. I didn't want to hook that back up again. And I think, okay, I've gotten out of Dodge. You know, we had the vein sort of under the skin here. Let's just chill. Everything looks okay. So we went from really badness, threatened skin paddle, vein. Yeah, I thought I fixed it right. And here's a couple of days later, it augured in. Now, the interesting thing is we still had signals in the artery, and actually I had a venous hum. So now we have a dead skin paddle. We have a huge plate, and I'm thinking this is not good. Quote, what do I do now? So burning bridges. What bridges did I burn? Nothing, but you know, what am I going to do? Another free flap, a pedicle lat, a big piece of meat anteriorly that with a fused shoulder. So we designed just basically a thoracoacromial perforator based flap here. We brought that over. We got rid of the skin paddle. Here he is, sort of temporizing. We skin grafted that. And this is him. You can see this is his iPad. This is what he looked like during the war. And okay, but here's the bottom line. In between what you just saw with a healed fibula, the artery and vein signals were always there. He pussed out. I had to take out the plate at like 6 weeks. I'm thinking all of this is going to be lost. And sure enough, the fibula itself was okay. And I think I rescued, or quote, what am I going to do now? What I did now was just basically perforator-based transposition flap to cover up the plate, give him the soft tissue that he needed. And again, here he is. And if you look here, fibula is incorporated. He's bridged this. The only thing remaining is the spring plate, not draining, and he's back in Ukraine. So, Babak, there you have it. I'm going to, I guess maybe, let's say, close this out, or let's see, how do I stop sharing here? That I don't know. But okay.
Great. Scott, great case and very difficult problem, and it's tough salvage. We have a couple of minutes here. So can you take us through what you think happened with that skin paddle? I mean, obviously with perforators, there's sometimes the skin paddles can take a bit of a hit if it's kinked or so on. But what's your thought about what happened to the skin paddle?
You know, I think we had edema, not infrequently, and I've seen this in free fibs, more in the lower extremity than upper extremity. His soft tissue envelope from the blast was really bad, and as things, you know, had a ischemia reperfusion and edema just on the massive dissection. I think the perforators became tented as the skin paddle was elevated away from the axis of where the fibula was sitting, and a venous thrombosis as well on the loop. As I said, you know, we were able to fix it and get it back, but the venous limb augured in, it crashed, and I think it was probably due to edema, because the loop was humming for quite some time. And as you saw, Babak, at the end of the case, things were okay. That doesn't mean anything. And so once we got behind the 8 ball, even though we did a heroic interposition venous graft, I think the ischemia time and just the fact that we have to de-inset and everything was beat up, those little perforators just said, the hell with you, I'm going home. And so we lost the skin paddle, but again, always had excellent arterial flow and good venous outflow, to tell you the truth. And that's how I'm putting it together. And the fact that he pussed out a couple weeks into this and yet healed the fibula. The fibula hasn't melted. He's not draining. means that we lost the paddle, but not the entire fibula, which I was also concerned about.
Mhm. You know, that's a great salvage. And something that I find not uncommonly is with an osteocutaneous flap, you know, you find the perforator, you get the skin paddle, and in theory, you say, okay, I need some skin. But oftentimes in reality, the skin paddle may not be exactly where you want it to be. And you don't have the degrees of freedom of a second free flap to place it
Right.
exactly where you want to go. And so sometimes I find that when you're trying to move the skin paddle to fit where the defect is, and you may end up stretching it a bit or kinking it a bit without really knowing it. But yeah, I mean, we've all had that happen. So, but
I
great
think
case and
that
great salvage.
that last comment is very appropriate. Again, you know, I thought, okay, we're going to have that panel a little more proximal to augment a bad anterior shoulder region, and we didn't. And it's like, okay, do we accept all this or try to, as you said, stretch it, move it, and you know that's a disaster. So I think you hit the nail or the plate on the head. Thank you.
Great. Thanks again, Scott. Fantastic talk and fantastic case. And if we have additional questions, we'll get to it at the very end. Great. Our next speaker, Dr. Chris Peterson. Chris, take it away.
Good evening. Thanks, Bollock, and everybody for having me tonight. I kind of think I don't burn many bridges, but this was a case that there were some bridges burned, and where's the dang? Well,
Looks like it's the end of the slideshow.
great. Perfect. Let me unshare and start again. You know, you forget about technology and old guys, so what can I say?
You know, the Zoom's been a little finicky tonight. I don't think it's you.
Well, I had it. Do we have our tech advisor here?
Let's see.
It,
Ilya, would
it looks like they did the slideshow. If you tried using the like up key to cycle through it, go back to the
The up
beginning.
key. I gotta get it on the screen first. Is it on the screen? Because I can't see it.
we
Mhm.
see the end of slideshow again? We don't see the what happens if you hit one enter? That should go to the first slide. If not, you may have to exit and get back. Stop sharing and reshare.
Okay, we'll try it again here. I apologize to all the people that are online.
No worries at all.
There we go.
Okay, starting. There we go.
Oh,
So
yeah,
I
we
see.
got it.
So we see
We
your
got you.
your thumbnails as well, but we haven't gone
Yeah.
full
Yeah.
screen yet.
You can click from beginning up there to the top left.
Yeah, I got that part.
There we go.
Huh. It says end of slideshow again. That's interesting. I don't think I've seen that.
Well, if necessary, we can go through the slides on the
Yep.
like that. Okay.
Sure.
I'm going to try from
We
beginning.
we see that, Chris. We see that.
I'm going to try from beginning one more time. End of slideshow, I guess.
Yes, it says again, end of slideshow, please. I don't know why.
Stupid. All right. It worked before. We tried it out. All right. I'm just going to leave it on like I'm going through it. All right. Thanks everybody for coming. This is a case I did several years ago, but I think it shows a few principles. Julius Caesar said experience is the teacher of all things. And I think as you go along in your career, really, you learn that more and more. It's difficult to anticipate everything that can happen, but it helps to have experience. And the more you know, the better you can manage problems and always have a backup plan. But you need to know a wide range of options, flaps, donor sites, anatomy, and frankly, more than just the ALT is helpful. And obviously, you need to be creative. 34-year-old software writer in Austin was helping his new father-in-law dig post holes out in the hill country, and he got his hand caught in a gas-powered auger. Came over on a Sunday afternoon and was replanted by one of my younger partners. And Monday afternoon, the anesthesiologist called me and said, "You need to come help." And it was the fourth take back. In case you don't know what one of these things is, this is this deal that digs whole post holes in the ground, and you get your hand in that, and it will eat your hand. So he got his hand caught. Here's the X-ray of the proximal stump. Here's the X-ray after the fixation was done. I don't like to throw stones, but I think would have been better to spend more time on looking at this than I'm going to try to start the slideshow because I've got several of these that they're animated. Lose it again.
So on the, it
Yeah.
says end of slideshow, but on the bottom left, if you move your mouse, see if you can just go back.
As I said, but I've got several stacked pictures on these, but you see what I'm saying, Bob? Like, I know how to run this, but that was 2 X-rays. But at any rate, so I get called in on Monday evening, and here's this guy's arm, connected with vein grafts, plates, few little things connected. But I say, this is ridiculous. It's his non-dominant hand. I walk out to his family and say, this is ridiculous. You know, we're not going to put this back on. And they refuse. So I get the vein graft to the dorsum working, and I wrap everything in a latch flap hooked to the vein grafts. Now, this is not burning bridges, but I thought this was hopeless, but it actually worked. Put him in a cast, sent him home. Looked pretty good until he came back to the office. And here it is when he comes back to the office. That's the latissimus flap all around here. But when you hold it up, it's completely dehisced where I sewed the 2 edges of the flap together. And so I go out to his wife again, and I said, look, this is a very intelligent lady. And I said, look, you know, this is unreasonable. You know, and he refused amputation. His hand's alive via vein grafts to the arteries and veins. There's no muscles or nerves hooked up. The bone and the hardware is exposed completely. And the plumbing is really complicated already. So he's going to need innervated muscle, probably nerve grafts, maybe more. And I can't talk him into letting me take it off. So at this point, I'm going, well, gee, I do another free flap, and then he's probably going to need a couple more free flaps, and everything's to vein grafts. So I kind of did some lateral thinking and lifted his rectus abdominis muscle and thought, well, this will probably work. Pedicle muscle flap, and wrapped it around his arm, and it actually worked. Got everything covered. At least it looked like it was going to be pretty good. This all healed up, and at about 4 weeks, I took this down, and it actually looked pretty good. He was doing well, no problems. Here it is, side view. And again, kind of amazing to me, but at 4 weeks, you take it down. I've done a few of these in my career, actually bleeds back from the artery. And so that was pretty cool. And then he comes back into the office about 6 weeks later, and the fellow sees him and says, he's doing great. He's just got one little spot of granulation. You see that little red spot? It's not in a scar. It's not in a skin graft. I mean, that is doom. Okay. That is absolute doom. So we get an X-ray, and everything is rotten. His distal radius is rotten. He's not healing. There's loose hardware. Everything's falling apart. You know, I again try to have what I call the come to Jesus talk with the family, and they're not having it. So I basically take all that down, put him in an X-Fix, try to pin his distal radius to his ulna so there's something salvaged. Just as in the middle of the case, you can see a large hole in the middle of his arm. Put a couple beads in there, and you know, eventually this all healed up, quit draining, and did a double barrel free fibula on him, and it did fine. And this is hooked into vein grafts as well. So all these things I'm putting in there are hooked into scarred in vein grafts for the artery and vein. And I let this settle for maybe 6 or 8 months. And finally, I went back at about 12 months after replantation, took all his sural and grafted his median nerve, and then did an innervated gracilis. And everything healed, quit draining. I had to fuse his wrist. He developed protective sensation and some motion. But his arm is made of all the saphenous vein from both legs. His right latissimus is a free flap into vein grafts. His left rectus, his right fibula into vein grafts, most of skin graft from his legs, all the sural nerve from both legs, and his right gracilis into vein grafts. And I'm still thinking this is kind of ridiculous. And I don't, unfortunately, can't show these slides very well, but he comes back about 2 years later and actually has grip. I can maybe move this. There he is at rest. Here he is with grip. And the funny thing is, he goes, the last thing he told me was, I'd do it all over again to have my hand. He has protective sensation. This is a fake shot. He can't grab this, okay? I put it in his hand, but nonetheless, he has grip. The guy loves it. And, you know, so I kind of burned some bridges in the beginning, think I hooked up to these vein grafts, but nonetheless, you got to be creative and work with what you got. And this is not burning a bridge. This is blowing one up. This is one of the bridges in Florence in World War II. So be careful you don't blow them up. If you burn them is one thing, but don't blow them up. So thank you.
Thanks, Chris. That's
Sorry about the
that's
technical problem.
no worries at all. That's a phenomenal case. And I don't think this is a case where you burned a bridge. I think you were handed a very, very challenging, difficult scenario. I guess the question, the question is always whenever you do these replants and stuff, it's, when do you decide to obviously, throw it in the bucket, right? And, he was refusing a revision amputation, obviously, so your hand was kind of forced here. The question is, if you had seen him originally when he first came in, like what were your, it's hard to know in retrospect, obviously, but what would your thoughts have been at that time?
I mean, I would have probably told him he'd be better off. I mean, he didn't have enough coverage over his proximal stump. He'd have probably been better off. I mean, at the time, it would seem, just doing his latissimus around the stump and saving that and getting him a good prosthesis. I mean, he was literally probably 3 years before he had any function. But again, he loved it. He ended up being an administrator at the University of Texas, but I'm not sure I would have replanted that. I mean, you guys probably would have, but I'm saying, but you're well aware that, no, I'm saying you're very skilled, but in the beginning, you're well aware that you're going to have to graft his nerves. He's not going to have any functional muscle. You can almost predict his bone's going to get infected, but I would say to the young crowd, don't spend 3 hours doing fixation on a case like this. Get the bones together in the most expeditious manner and then get things revascularized. So,
Yeah. And don't be afraid to shorten a bit either.
oh yeah,
Help
absolutely.
come up with that for sure. And then the only other question I had is any technical tips on kind of digging out these, vein grafts, multiple times in a scarred bed. I mean, obviously, we've all been there. It's tricky, but do you have any special tips or tricks for doing that?
Be careful. That's a stupid answer, I realize. I mean, you got to go slow. You got to get in the plane. I would rather cut a hole in it than rip it with the scissors. I'm always telling my residents, use the knife and don't spread too much. You've got to go down to these vein grafts. I Doppler them out so I kind of know where they are.
Yeah.
And then I go down right on top of them, and you'll eventually be able to see kind of the edge of the vessel. And then sometimes I'll take them out with a little beaver blade, very, very, very carefully. Because if you start spreading too much, you'll rip a hole in them. And once you've ripped a hole in them, I mean, everything's gone. His hand's going to die. Everything's going to die. So you just have to go about it really, really carefully.
And I've been guilty of that myself. I have torn vessels a couple times here or there.
Yeah.
So it's painful to have to go back and fix it. Scott, looks like you have a tip or trick they want to talk about.
Yeah, just amazing case from Chris that I've seen. I recently had to go back and use an AV loop that I had used on an ALT for a sarcoma, and the anesthesiologists were there. And I know lots of people use ultrasound or whatever, but the anesthesiologist actually had their probe that they used and showed me the AV loop exactly where it was. And I was able to go down on that pretty easily. So that, the ultrasound from anesthesia right there can help you go back and dig those things out.
Yeah, that's a great tip. And actually, one question that I thought of, Chris, when you were showing that rectus, the conventional wisdom is that muscles may end up being pedicle dependent longer than skin flaps would. What are your thoughts on that in light of the fact that you were able to divide the pedicle in 4 weeks?
I mean, you just have to get a good soft tissue interface. You probably have. I've done 3 or 4 cross leg free flaps before, where you hook the vessels in one leg and lay it on the other leg. And as long as you get it, I agree with you. I've always worried about that, but you get enough soft tissue interface, and the capillary beds do hook up, obviously. And so I was very nervous about that, but I tried to put a big clamp on the pedicle and listen with a Doppler, and I could still hear the signal in what was the deep beam pre-epigastric. I guess it's his posterior osseous now, but at any rate, yeah.
Great. Well, Chris, thanks again. Phenomenal case and amazing salvage. Appreciate that. Next up, David Coleman from Yale. David, take it away.
Awesome. Thank you so much for having me. This is a great honor to be here. Very excited. And thanks to the association for putting this together. Oh, sorry. I'm going to talk today about vascular reconstruction and the terminally
David,
ischemic hand.
sorry to interrupt you. If you can swap the
Oh,
displays.
yeah,
So
I thought
we
I'd
can
fix
see,
that. There we go.
There we go. There you go.
There we
That's
go.
it.
All right.
Perfect.
Thank you. I thought I was going to make it with no technical glitches, but I guess the entire thing is cursed. So today I'm going to be talking about vascular reconstruction of the terminally ischemic hand, and is it just water under the bridge, or the burn bridge in this case? So vascular surgery of the hand was an early passion of mine, mostly because the thing that brought me into plastic surgery was microvascular reconstruction, and I love vascular surgery in the hand because all vascular surgery in the hand is microvascular surgery. And when we reconstruct the vascular supply to the hand, we really have a very different thought process than when we say do vascular surgery for the lower extremity. In the hand, we're really trying to restore the anatomic perfusion of the hand, be it the palmar arch, digital vessels, whatever, but we're trying to directly reperfuse each subunit of the hand and each digit. It's not as simple as inflow and runoff. When we think about the lower extremity, we think about how much blood volume is getting into the leg, and then how far does that blood volume make it through the arterial tree towards the foot. We think more about the hand, about getting direct perfusion to each of the subunits. And then the other important thing to know about vascular supply to the hand is that it is very highly related to nerve and motor function. When we replant fingers, we got plenty of time because the fingers can tolerate ischemia, but the muscles in the hand really cannot tolerate ischemia. The sensory function in the digits diminishes almost immediately when there's poor perfusion. And so that coupled with ischemic pain, it can be a debilitating problem having poor blood supply to your hand. And typically when we're seeing vascular lesions in the hand, probably the most common thing we see is hypothenar hammer syndrome, or ulnar artery thrombosis. This usually presents as a subacute thrombosis, maybe some repetitive, sometimes just single time trauma to the palm that causes some pain, sometimes ischemic ulcerations. And the kind of the gold standard is resection of the thrombosed portion of the ulnar artery and reconstruction with a graft. In this case, we had to resect a portion of the ulnar artery and palmar arch that actually gave a branch off to the common digital of the fourth web space. And you can see here, we were able to find a vein graft where as it was reversed, there was actually a tributary, or a branch, I guess you should say, that diverged from it on the dorsal hand. So we were able to do an end-to-end anastomosis both to the palmar arch and to the fourth common digital vessel. Here's another example. Again, this time we couldn't find a good vein. We actually had to plug in end to side. This again is the fourth common digital vessel going end to side into our vein graft. And just another case. This is actually a 4-year-old. Probably in an adult, I wouldn't worry too much, but in a kid, I tend to really try to restore as much anatomic flow as possible. This is a 4-year-old who had a penetrating injury to the palm, came in with painful pulsatile mass and some numbness in the third web space distribution. Ultrasound showed a several millimeter aneurysm, which was resected and was reconstructed with the vein graft. So argument often comes up, do we use vein grafts or arterial grafts? In my training, I almost exclusively use vein grafts to reconstruct arterial defects. But I've actually changed my practice. Now I'm almost exclusively using arterial grafts, be it as Marco Godina first described, using the subscapular system. It's interesting. Old always becomes new again if enough time goes by. This was an article published just a couple of years ago in PRS Go, and essentially they recapitulated what Godina mentioned in the 80s. So, our memory tends to be somewhat short, but this is nothing new. My actual preferred arterial graft is the ALT pedicle. This is actually an ALT flap, but you can see that there's a pretty robust branching pattern that can really match all of the different caliber and structures of the or sizes of the palmar arch and digital vessels. Here's an example of using that. This is a guy who sat in an outside hospital on a heparin drip for 3 or 4 days with pulse ox in his middle finger that was in the 50s at best. When he finally showed up, we took him emergently to the OR. We resected a good section of his ulnar artery and arch, and we had to reconstruct 3 different, the digital vessels to the 2nd, 3rd, and 4th web space. This is the descending branch of the lateral circumflex femoral artery with a nice branching pattern that allowed us to really be specific. This picture on the left was after we immediately went left tourniquet down. What I unfortunately didn't capture was that his ring and small finger pinked up nicely, but his middle finger remained pale. We extended our incision with a Brunner incision over the middle finger, actually found that he had thrombus extending all the way, presumably all the way to the tip of the middle finger down both digital vessels. And I actually ended up resecting another 3 to 4 centimeters of the radial digital vessel and replacing it again with some arterial graft. On the right is his post-op day 1 pulse ox on the middle finger. Not a great waveform, but 90% oxygenation I will take. And he's doing well. Still having issues with cold intolerance, and now some kind of vasospastic Raynaud's type phenomena, but otherwise very happy. But kind of what I want to touch on mostly today is what to do with chronic hand ischemia. This is a topic that I was first introduced to by one of my mentors, Dr. Scott Levin, when we wrote this paper together, looking at a systematic review and a series of cases that he did at Penn, and really, this is an often neglected topic in that I think that we typically, maybe not are taught, but we tend to presume that patients with chronic ischemia of the hand, digital vessel that are occluded, and ulcerations and fingertip necrosis are unfortunately in a bad way. They really aren't really good candidates for reconstruction, but I would beg to differ. And the case I'll show is a 56-year-old diabetic with chronic kidney disease on peritoneal dialysis. He was referred from an outside vascular surgeon with these ischemic ulcerations on the index and middle finger. He's noticed these, but the number one thing he comes in when he sees me is, I've got my entire hand hurts all the time, nonstop, all 5 digits. Yes, these scabs kind of bother me, but I can't touch anything with my left hand because everything hurts all the time. Here's his x-ray. This is classic for a chronic kidney disease patient on dialysis, where they've got dense calcifications of their entire palmar arch and digital vessels. And then here is his angiogram from the outside vascular surgeon. This was about 6 to 8 weeks before I met him. And what I see here is that he has termination of his radial and ulnar arteries in the distal forearm, the radial artery about at the level of the wrist. But he has some reconstitution in the mid-palmar arch. So when I see this, that is my target. I want to get some increased flow beyond the main occlusion in the hand at the wrist and get it into the hand proper. And hopefully it'll find a path to the fingertips. So my plan is to do a bypass. Again, in my initial practice, I was doing vein graft. So here I used the vein finder to map out dorsal and volar and palmar venous branches. And what I'm looking for here is that after I reverse this, I'm looking for a branching pattern that would allow me to, so maybe from here, I'll be able to take one that branches into 2 after reversal, into 3 even. But my plan was to take a vein graft, likely bypass from his radial artery to his palmar arch. In doing the dissection, do a sympathectomy to try to reduce sympathetic tone, potentially improve vasodilation of his palm and digital vessels, and hopefully that will get him out of Dodge. At the time, and if everything goes well, perform a revision amputation of his index and middle fingers. So plan goes as well, at least initially as planned. Here's our dissection. And what you see here, we've dissected out the entire palmar arch, ulnar nerve being retracted from the ulnar artery and vena comitans. And if you look closely, you can really see how calcified everything is. And I'll be honest, maybe I missed something on his angiogram, but after we let tourniquet down, there was no flow in any of these vessels. And it could have potentially been my rough handling or manipulation of the calcified vessel. Sometimes can dislodge intima or thrombus, and potentially propagate an occlusion. But at the time we let tourniquet down, direct Doppler exam within the palmar arch where I was expecting to find a target had no audible Doppler signal. I call my buddy, vascular surgeon, to come in and see if he can do an angiogram. Again, I had an angiogram to work with, but either something changed in the last 8 weeks or something changed intraoperatively. And here's his angiography. On the left, you can see the brachial artery as it crosses the elbow. You got a nice bifurcation of the radial ulnar arteries, but as you get towards the distal forearm, where we should be looking at the radial metaphysis, there's literally no filling. We ran this many times, only to end up closing his incisions and just performing the revision amputation. So this is, we did, I guess you could call it a sympathectomy as well, but again, the sympathectomy wasn't working in situ. So really this was a glorified fingertip amputation. And so we close him up, put dressings on. I plan to see him 2 weeks post-operatively and have a discussion with him about what to expect and future options. So, again, this guy is a highly functional person. This is his left hand is his dominant hand. And so, I'm trying to think about how to have this conversation with him. So 2 weeks post-op, I see him again. I take down the dressings. And again, and full disclosure, I was the one who put on the dressings. I can't even blame this on the residents. But when I take off my Coban dressing, everything that was covered in my Coban dressing is now black and necrotic. So in addition to the fact that he continues to have 10 out of 10 ischemic pain, I've now killed more of his fingers and still need to perform a revision amputation that needs to heal. So I'm essentially back to where I was with a worse amputation level. So really, what are my options? There's no anatomic options to plug into. There's no inflow beyond the elbow, just maybe proximal forearm. No targets to bypass to, but he does have a nice healthy venous system as we looked at before the index case. And so really, I think the best option for this person is a dorsal venous arterialization. This is kind of the simplest, maybe non-intuitive, but at least the simplest in my hands way to give this guy a shot of healing his amputation. So dorsal venous arterialization consists of typically skeletonizing and dissecting the cephalic vein, ligating its branches / tributaries to make sure that there's no shunting of blood flow, and then performing valvulotomy of the entire length of the cephalic vein, and then doing an endoside or end-to-end anastomosis to the brachial or radial ulnar arteries. In this case, we did an endoside into the brachial because that was where I felt he had reliable flow. And immediately on the table, once we let the clamps down, you can see a nice pulsatile cephalic vein. The other important thing to think about too is within the hand itself. So we go back. When I look at his dorsal venous system, I'm going to want to probably, as the cephalic vein comes down the radial side of the dorsal forearm, it's going to hopefully send blood into all of these venous branches. So it's important to think about that and to ligate these potential shunts that will bring the blood back up the arm. So I would clip and ligate each of these branches that potentially shunt blood back up the arm too. And here's his on-table angiogram as well. And this is actually a year post-op. So he came back in 2 weeks, pain was gone, was healing, took him a little while to heal. But this is him at a year post-op, still has a healthy Doppler signal in the cephalic vein at the level of the radial styloid. So this is I mean, I wouldn't call it a win, but at least got me out from under a burning bridge. But this dorsal venous arterialization has other uses as well. I've done it for palliative indications for a patient who clearly has impending tissue loss. You can see on the left side, the soft tissue is chronically ischemic. I cannot imagine that that's going to improve over the course of several weeks to months. That likely, I mean, almost guaranteed, in addition to a revision amputation and a ray amputation of his index, he's going to require middle and ring finger amputations. But mostly we did this for pain control. Again, this patient had 10 out of 10 pain at all times. And so we reperfused his hand. He did end up getting revision amputations, and he unfortunately expired about probably 8 months after this operation, but his hand ischemic pain was mostly gone. It was essentially down to a tolerable level that could be controlled with pain medicine. And here's a similar patient where again, we've ideally teed him up for healing in the dorsal hand. Now, so in terms of indications, like I said, there's really 2 indications I would say for a dorsal venous arterialization. On the left, this patient has obviously significant ischemia and necrosis, but the quality of his soft tissues in the remainder of the hand, I think, are mostly normal, mostly supple, and I can expect that I could perform a revision amputation and get those skin edges to heal, provided there's enough oxygen getting to the skin edge. On the right side, I mean, he's got complete intrinsic wasting, and his middle and ring finger, in addition to his index, are not long for this world. But I think it's worthwhile to provide a palliative pain treatment and reperfusing the hand. Now, what are some things you don't want to do? You don't want to perform a dorsal venous arterialization when there's any active infection. My concept for this patient, he had a ray amputation of his middle finger that I couldn't get closed, and I wanted to optimize him for healing. And unfortunately, I don't think I did a good enough job of clearing his infection. In this situation, we're not only reperfusing the hand, we're also cutting off a major source of venous outflow. So the edema in this patient is going to end up diuresing out through his wound, is going to actually turn his infection into a soupy mess. And that is pretty much what happened. So this is him on the table before we did the venous arterialization, and fast forward about 6 weeks, and the infection got continued to spread. I think his ischemic pain was questionably better at the end of the case, and eventually he had a 4-finger amputation and just had a thumb and palm. So just some pros and pitfalls. I think all hands deserve the right to be perfused. I don't think we should generally write off patients just because they have complex medical histories. Obviously, we need to see the forest for the trees. If patients are nearing the end of life, they could be a potential candidate for a palliative operation, but I don't think every single patient that has chronic ischemic pain and wounds deserves this operation. But in the right patient population, but right indicated patients, it's a great operation. It's important to establish the goals clearly with the patient and to make sure they know exactly what you can provide them, mostly to treat ischemic pain. That in my hands has been quite reliable, but also in either to tee them up for a revision amputation or to prevent further tissue loss, depending on the patient's soft tissue and their chronicity. It should be maybe not guaranteed, but discussed sensitively. I always recommend an anatomic vascular reconstruction, artery to artery anastomosis in my hands, so an arterial graft rather than a vein graft. And if you see any perfusion in the palm, go for it. It's the best way to go. Finally, kind of more of what we just said, this is not so much microvascular surgery when you're doing an end-to-end or end-to-side anastomosis to the brachial artery. It doesn't even really require a microscope oftentimes. And it can be very effective at improving pain relief and to a lesser degree tissue loss. You want to make sure you take a look at the patient's venous system. If they've had any dialysis access in the arms or fistulas, if they've had multiple IVs placed, or if they're IV drug abusers, their venous system is likely not a good candidate. And again, you cannot have an active infection when you do this. And then finally, if you start thinking about doing this operation, you got to be very careful what you wish for. because once people find out that you're interested in taking care of these problems, you'll have a lot of these patients in your clinic. So thank you very much. I appreciate everyone's time and consideration.
Great. Thanks, David. That was a great topic, and these are really challenging cases. And as you said, a lot of them, not all, but they not uncommon, they end up being somewhat palliative because this is just kind of a symptom, if you will, of their overall health as well. So we've had many cases where we, did the operation, but unfortunately, a few months later, the patient didn't make it. A question about the arterial grafts. I've definitely done arterial grafts, and I think it's really nice, especially for the branched segments where you need to reconstitute, a couple of common digitals, as well as the arch itself. What do you do if you have just a straight up interposition graft need? So one artery proximal, one artery distal. Do you still go with an arterial graft for that, or do you just take a vein?
Yeah, so I always kind of think about it in terms of like the fluid dynamics. So depending on the diameter of the vein or artery and the potential compression force. So if it's a long segment that's very narrow, I'd like to have a vessel graft that is robust and will not be compressed easily. So, as your graft gets longer, the resistance to flow goes up. So for a long interposition segment, veins are much more likely to be compressed with swelling and a tight closure. So if it's a short segment and it's a large diameter, I'm okay with veins. But I tend to, if it's anything more than branched, so if a branched segment, definitely would prefer artery. But similar position, if it's a long graft, I would prefer an artery just to make sure that I don't have any issues with perfusion later. That's mostly superstitious. I mean, I'll be honest, I haven't had many problems, but I just feel a lot better about it. And I think in microsurgery, oftentimes we're treating our superstitions with that one final stitch or, extra gel foam around the anastomosis or whatever it might be.
Yep. Scott, I see your hand up. Was that from before, or do you have a
No,
question,
I
comment?
just, David gave a great talk. And I do want to say one thing to the audience. While we've written and I've done a lot of this work as he has, I want to give credit to Chris Peterson, who as early as 1988, when I was his resident, this is 36 years ago, he went off to Melbourne and worked with Julian Prebes in the concepts of arterialization of the venous system. And Chris had an unbelievable career in general surgery with very keen interest in vascular surgery and has taught me a lot. And I think Babak and Sono, the message here is, as Kennedy said in his 1961 inaugural address as president, the torch is passed to the next generation. And Chris taught me a lot. And I think he, as a board certified general surgeon, has carried this torch, and others have adopted this. I know how much work you do at Bunkie Clinic. And I think maybe David could comment. We have to get the message out to our rheumatologists, to our vascular surgery colleagues, to our endocrinologists, to our transplant surgeons who do AV fistulas and diabetics for access and then have steel phenomena and so forth. So this is a huge domain in hand surgery. And, obviously, as David said very appropriately, the tools of reconstructive microsurgery are essential here. And I know Chris has done it. I've done actually, and I think you have, bypasses within a threatened digit, at the PIP joint level with an ischemic pulp. You can revascularize that, and Koshima calls it super microsurgery, but it's just a digital bypass that we do not infrequently in replantation. So I want to just recognize Chris, and I'm sure he would have some comments, but David gave a really beautiful talk and very proud that he's continuing at Yale this aspect of reconstructive microsurgery within hand surgery.
I really appreciate that.
are-
I will just say that the vascular chapter of Green's Hand is written by Chris Peterson, which is where I initially learned about this operation. And I actually called Chris Peterson this morning to make sure that all the things I was going to talk about, and I didn't miss any pearls. And so I apologize. I should have absolutely mentioned that. And thanks for reminding me, Dr. Levin.
Yeah, actually, Scott, I think your comments are right on. And when I saw the topics being presented, and I saw David was going to talk on the ischemic hand, I was like, oh, well, we have Chris on the on the Zoom, so I'm sure you'll have some comments. And Chris, I think I remember, if I remember correctly, a few years ago, I forget if it was at the Hand Association or ASSH or something, but there was a panel on operations I don't do anymore, and I seem to recall you maybe have mentioned venous arterialization. Am I correct about that? And if so,
Yeah,
why?
that's where I didn't do it very often, but if you can't
Okay.
do anything else, it works. But if you can arterialize the arterial system, which I started concentrating on,
Yeah.
and we wrote up, I don't know, several years ago, long in situ grafts into the palmar arch. Even if there's a little bit of arch, you can bypass to it and it'll generally help. But I don't take any issues with David showed the case where it was kind of infected and it fell apart. You can't do it when they're infected, but I did a number of those. And then Gabe Kine called me once and said, "You never wrote this up. Can I write it up?" I said, "Sure, that'd be great, Gabe, if you want to write them up." But I tried to concentrate on arterializing the arterial system more, because if you can do that, it works better. But I mean, I've got people whose hands are pink and they have pulses in their veins, and that lasts for quite a long time. So I applaud David. Those are difficult, great cases. And thank you,
Yeah, these
Scott,
are
for the kind words.
these are some of the more difficult cases that we see for sure. And I think we've had some good success with venous arterialization in cases where there was nothing else that you could do. So I think those are really great examples, David. And thanks again for a great talk.
Thank you.
All right, we're going to go next to our next speaker, Dr. Stephanie Russo. Stephanie, go ahead and take it away.
Hello, thank you for having me. I appreciate that invitation. Get my slides up here.
Perfect.
So
Looks
I'm going
good.
to turn my camera off, so hopefully the sound holds out. But I'm going to be talking about burn bridges related to a median nerve injury to try to represent the nerve aspect of microsurgery here. So this is a case of a 7-year-old who had a left elbow dislocation with a medial epicondyle fracture. He was seen by an orthopedic resident in the ER who noted paresthesias in the median nerve distribution, but intact AIN function. He had a closed reduction and cast application performed in the emergency department. He was seen for follow-up in the office with these x-rays about a month after surgery, or a month after the reduction. Was noted to have median nerve palsy, motor and sensory, and was referred to me about 5 or 6 months after the injury for persistent median nerve palsy. When I saw the patient, he had about 45 degrees of pronation, so incomplete but present pronation of the forearm, and no other median function distal to that, no FDS, FCR, AIN, or sensory function. And his elbow range of motion was limited at about 20 to 110 degrees. In seeing this patient, it may raise the question whether to obtain any additional ancillary studies or not. In this case, he already came to me with all of the studies, including an ultrasound that showed some hyperechogenicity of his forearm flexors, an MRI that was read as negative, and electrodiagnostic studies that showed reduced amplitude in his sensory nerve action potentials, as well as his motor CMAP action potentials. Amplitudes were reduced, but neither one of them was absent or NR. And then he had fibrillations and positive sharp waves in his median innervated muscles distal to the pronator with no motor units. And he still had fibs and positive sharp waves, but did have motor units with reduced recruitment in his pronator teres. So here's what his exam looks like. He has intact supination. He cheats with pronation. When I block his elbow, he doesn't rotate quite all the way down. He has intact radial nerve function. You can see him cheating when he makes a fist there. He has intact ulnar innervated FDPs, but is pulling his index down with the long finger. He has no FPL function, and he has no FDS function. When we look at his hand, it requires a little bit more, or his thumb, a little bit more careful exam, because this certainly looks like palmar abduction, but he has profound thenar atrophy and is compensating through his flexor pollicis brevis with the ulnar innervated head. And then his elbow, I apologize for the maybe in video that might cause some motion sickness here, but he has reasonable but reduced elbow range of motion there. And so at this point, my plan was to explore his median nerve. It seemed likely that it was in continuity, as he had some amplitude on his sensory and motor action potentials on the electrodiagnostic studies, but clinically no function at about 6 or 7 months after his elbow dislocation at this point. And so when I stimulate his his median nerve proximally, you see he has this forearm pronation consistent with his clinical exam, but no wrist or finger flexion at all. And so as we follow out the median nerve, identify it proximal and distal, it took me a little while to find it initially because it was coming so far ulnar. You can see the blue backgrounds under the median nerve proximal and distal, and the forceps is pointing at the medial epicondyle. And so this nerve appears to have gotten trapped in the medial epicondyle fracture site and is now traversing through the humerus with no function. And so it does not appear to be in the joint. I'm exposing the ulnar trochlear joint there, and it's kind of running right along the medial side of that. And so, then the question is this a salvageable nerve at all? Can they dig it out of the bone, and will it recover, or do we start over about 7 months from the injury? But he's 7 years old, so I decided to start over. Went and got sural nerve autographed and excised proximal and distal to the humerus. Ended up with about 6 centimeter cable graft. I had to use one cable from the MABC also to augment that. And then another sort of question for debate is whether it's worthwhile to also decompress the median nerve at the carpal tunnel, which I did just to try to take any sources of compression off and potentially help augment his recovery. So at his 2-month post-op visit, his elbow extension was a little bit better. He's still lacking some elbow flexion. His tenelle is at the level of about the antecubital fossa. He still has his partial pronation and no other median nerve function as expected. And at 6 months, he has near complete elbow flexion. It's still a little bit less than the contralateral side, but he can kind of just touch his shoulder now. And he has just a couple degrees of elbow extension contracture. He still has that thenar atrophy here, you can see in his left hand compared to the right side, but he's starting to get some recovery back in his AIN function. Here you can see his DIP at the index finger flexing and his IP joint at the thumb. He does not really have any additional thenar function yet, and his FDS is not coming through yet. And so in this case, I think the burned bridge was perhaps missing an opportunity for earlier intervention with his entrapment in the humerus. And so this paper published by Matev in 1976 described this radiologic sign of entrapment in the median nerve in the elbow joint after posterior dislocation. And he described in kids, he described this kind of notch sign in the periosteal reaction. And in this case, it's perhaps even more distinct in retrospect, where you can see an opening or a loosened area going right around the median nerve there. And on his MRI, you could track the median nerve coming through that same space. And so I think that was actually mentioned by the referring provider, but but perhaps not acted upon. And so I thought that was an interesting point and something that is worth being mindful of in these pediatric elbow injuries. And thank you for your attention and the opportunity to speak.
Thanks so much, Stephanie. I think, it's nice to operate on kids because obviously they do so well. It was a very tough problem, but I think with those the nerve grafts, excuse me, the patient did quite well. If you can remind us, when the patient had the original injury, was the median nerve working clinically, or I forget if it was intact or not
Yeah,
at that
so
time?
the documentation from the ER visit was that he had median paresthesias, but the
Okay.
AIN function was intact.
Okay.
But at his first follow-up visit with the orthopedic attending, the median nerve was documented as out.
Yeah, it's interesting because we've seen plenty of cases where folks attend closed reductions in limbs that are either numb or insensate, and it's just so difficult to do that and know for sure that you haven't entrapped a nerve or done something. So I think it's something really good for I think orthopedic surgeons to know about, not hand surgeons, but just in general when folks are doing the original reductions. Thanks so much, Stephanie. That was a great talk. And now we're going to move on to our next speaker, Dr. Jeff Friedrich. Last but certainly not least. Jeff, take it away.
Thanks very much. Is it presenter view or regular view?
This regular view looks good.
Okay, good. Well, thanks so much for the opportunity. I'm really honored and to have been asked to be on this, and it's actually good to be last among such a distinguished group, to be the Red Lantern, as they say in the Tour de France. So I'm honored to be in the Red Lantern position tonight. I am going to circle back to the kind of trauma etiology that we started off with Dr. Levin and Dr. Peterson, although I will say it's been great to see the variety here with Dr. Cullen and Dr. Russo presenting some non-trauma things. But trauma is kind of our bread and butter out here in Seattle. And so I wanted to talk about a case that, the bridges may not be totally burned, but they're at least lightly charred. So that's what I'm going to talk about here. So, and many of you have probably gotten this call before, which is, our transfer center calls, and we talk to the outside provider and, something to the effect of, hey, we have a guy with a rollover MVC and his hand went out the window, and we took him to the OR for fixation and did some other things, and we just need to send it to you for coverage. So, it all sounds well and good, but sometimes if you dig a little bit deeper, there can be some other issues, and I'll show you those. I'll confess to getting overly excited about these hand out the window things. This has sort of been a little niche academic area of mine with the hand out the window injuries. And it's interestingly, the crash injury researchers call this partial ejection. We just call it a hand out the window. And so we looked at some vehicle factors and other things associated with that. And I was actually surprised to find that it's not people just riding down the road with the arm hanging out the window. Often the window's closed, and that centripetal force with rollover MVCs is what pulls the arm out the window and then leads the vehicle to roll over on it. And we even went into some other research on it, like looking at side curtain airbags and finding that they did indeed have a protective effect for some of these partial ejections. So if you have the opportunity to work with crash injury researchers, they're really interesting people. They're engineers and other types that have a totally different take and a different way to look at things than we do. And I just appreciate that different viewpoint. So this is the x-rays that we get. And remember, this is a rollover. So it's the prototypical crush injury. It's rollover MVCs and ATV accidents are perhaps the most destructive injuries that we can see. Because it's crush injury and it involves everything. And, this for me is one of those x-rays where my eye is drawn to the radius and ulnar fractures, which you can't help but look first. But then you look at some of the other things like the carpus and the carpal metacarpal joints, and you start to think, yeah, there's a fair amount going on here. And so this is how it arrives to us. They've got some allograft skin on, and that's what, in their estimation, needed the soft tissue coverage, and then has an external fixator. And that's just another view of it there. So, from the outside, it doesn't look too bad, but as we saw the x-rays, and as we now see these x-rays after the initial fixation, the outside does not belie what lies beneath, which it is still a fair amount of work to be done. And I'll go over some of the fixation and other lessons that I learned about for my own and how I can do things better. But we have a project on our hands with that. And so we talked to the patient and sort of naively said, well, we'll revise some of this fixation and then put a flap on it, because we actually correctly understood that he needed free tissue coverage over what was going to be exposed bone and neurovascular structures and tendons. So we got going with the fixation, and things are going along okay here with the radius and the ulna. We've got plate fixation on both, and then the gift just kept on giving. And this is one of the longest cases I've had to do, longest fixations that I've had to do, because the work that we then had to do on the carpus was just tremendous, and in no small part because this patient had been at the outlying hospital, I think in Idaho, for the better part of 2 weeks. You remember from that allograft that was on there, it had actually taken pretty good because it had been on the wound for a little bit. But this is an area where I could have done better, which is really estimating what was going to be needed and really taking a deeper dive into the radiographs. And so we spent a long time doing the complex carpal fixation, the carpal metacarpal joints, and even, as you can see there, fusing the thumb CMC joint. And I think a lot of this was really difficult. The reductions and fixation were quite difficult because of the time since injury. In my experience, the complex carpal dislocations or fracture dislocations, if you're dealing with those beyond about 72 hours after injury, it's, as my partner Doug Hanna likes to say, that's a bad day. And this was a bad day. We spent a long time taking this apart and then a long time putting it back together. And we looked up at the clock, and it's now 6 hours have gone by. And so we then had to abort our plans for flap coverage, because we were just exhausted. So, and literally exhausted. So we decided to go at it again tomorrow. This was actually during the pandemic, when there was actually no shortage of OR time in contrast to what we have now. So we were able to get an OR the next day and take another go at it, and chose to do a lateral arm flap. I think that this flap worked out okay, as you'll see. I really enjoy the lateral arm flap because I can innervate it, and because particularly that distal end around the elbow is so thin, and it works so well for palm and wrist and other areas around the hand. And I'll show you the drawbacks to it, though, particularly with the donor site. So this was our flap choice, and there it is there after a few days after takedown, and it's hanging in there. It got everything covered that we needed to cover, including the radial side of the carpus and the wrist and the neurovascular structures. This is something I think I've only seen one other time, and it's been with a perforator flap. And I guess you could consider a lateral arm flap technically a perforator flap, but this patient came back to clinic. This is now about a week and a half out, and the flap was looking like this. It was difficult to tell because of a language barrier if it had been dependent for a long time. But boy, talk about where your heart just stops, and you see this and you go, I got this flap through this acute period, and now it's looking really bad, telangiectatic, ischemic. Wasn't sure what to do, and so we did nothing. We decided to see what was going to happen with this, because now it's going on 2 weeks, and I felt like we could probably do more harm than good by trying to revise any sort of anastomoses. And so this is a learning point for me in trying to understand what the flap is telling me, and I think I just got lucky in this case and chose not to revise it, because then he came back another 2 weeks later, and all of that whatever that was, that congestion and ecchymosis and telangiectasia had, for lack of a better term, washed out. And so I think my best guess is that it was in a dependent position for a while, and really had it looking bad at first. And so a little bit of benign neglect paid off here, but I don't know if I would recommend that again. So that's another bridge, perhaps not burned, but at least lightly charred in this experience. This is, burning the bridge of an attractive donor site. I really love the lateral arm flap. As I said, its anatomy is reliable. You can reliably innervate it. It's thin. It's just ideal for hand. But it's got issues. It's not good for a two-team approach because it's hard to work on the upper arm and the hand and forearm at the same time with multiple people. And it's ugly. I mean, let's face it. This is a burned bridge in terms of the aesthetic of the patient and how they're going to present themselves to the world. And you could argue that that's kind of small potatoes with the way that the hand looks. But I think it's a consideration to which we perhaps need to pay a little bit more attention, at least for my own part. There's this fixation, and as you can see, the carpus looks all right. You could certainly argue that it doesn't look a whole lot different than when it came in, and I would not argue with you on that. I think that because of the delay to reconstruction of the carpus, I think there was some ischemic hits to these bones and some degeneration just through disuse osteopenia that really led this to turn to mush. So after the reconstruction, he surprisingly had a non-painful, really significant degeneration of the carpus and quite limited wrist and digit range of motion. And so I started walking down that path of capsulotomies and tenolysis and things like that with him. And then he has not come back. So I don't know if he got a better offer from someone else, or perhaps he's doing great and doesn't need my services anymore. I'm a little bit disappointed that I haven't seen him back to know how he's doing. That's how our fixation ended up after we got rid of a lot of the hand hardware and left the wrist hardware. And, I would say that that's, it's okay, but that carpus really, as I said, just rapidly degenerated, almost total degeneration, sorry. So the patient disappeared, and I'd love to get him back, but haven't been able to do so. So I as I said, I don't know that I totally burned bridges enough, or other people burned bridges enough that they collapsed in the water, but they're at least mild to moderately charred. I think we burned the bridge of time. We and other providers burned the bridge of time in terms of particularly those issues with the carpus and how long it took to get to definitive fixation and stable fixation. The bridge of recognition, recognizing it not only from the outside provider's part, but from my part about the extent of the intercarpal and carpal metacarpal injury led me at the very least to have a longer surgery time than I was expecting. I think there is a role for damage control surgery, and so I think the bridge here to some degree was burned. I think that and all of us can, I think, probably think a little bit more about this notion of damage control surgery. I think our orthopedic trauma partners do it really well. They, if a patient is sick, they get in, wash, X-fix, get out, and fight another day and come back when your team is fresh and ready to go. And I think that could have been done better in this case. I don't have any problem with putting the external fixer on a distal radius, particularly when things are dirty and gross. But get in and get out and stabilize the patient and have a frank conversation with the patient about what's going to be needed. So I think there's something to be said for that damage control surgery. And then for this patient, the bridge to home was charred. Here he is 2 states away. We deal with that quite a lot here in the Northwest. This enormous distances between patients' home and our center where they get definitive care. And it is really tough, to get people home, to help them stay home, and to not keep dragging them back and forth across mountain passes and things like that. So things that I continue to work on to do better with our patients from long distances away. So that's what I have. Love to. I accept any thrown tomatoes, and again, happy to be a part of this. And thank you for the time.
Thanks so much, Jeff. Great case, very tough case, and a lot of patterns that we've all seen. My first question has to do with obviously the initial operation you showed with all the fracture fixations. A lot of work that you did, and we've all been there when you go in there and try to get everything perfect, and the wrist bones just kind of fall apart. And then you look back and you say, should I have just done a wrist fusion or something a little bit simpler?
Mhm.
Because a lot of my cases, I'll see some similar, and they kind of progress to maybe not a formal wrist fusion, but essentially that's how they behave. Any thoughts on that? Because I've been there myself, and this exact thing has happened to me. And our patients are not as geographically diverse as yours, because it's not multiple states. They're usually in California, so we get to see them back and do the fusion on them. But any thoughts on kind of how to recognize that, or kind of advice to some of the more junior surgeons who are on the call?
I and I don't know if this has been written about, but it's and I mentioned a little bit in my presentation. I really think these complex intercarpal dislocations and carpal metacarpal joints, they are my two thoughts about them are they're often very easy to reduce, and they're also very easy to unreduce, and so they're wildly unstable, particularly with something like this. I do think there's maybe not an emergency, but an urgency to the intercarpal and carpal metacarpal, complex fractures, because it doesn't take long for those bones to get hypovascularized, and then we finish them off with our open approach, and they really degenerate rather quickly. So it seems counterintuitive to think about a closed fracture dislocation as an emergency or an urgency, but I actually think they are, more so than finger or metacarpal fractures or even distal radius fractures. So I that's why I said that bridge of time was at least moderately charred in this case.
Yeah, that's a great point. I think, Scott, you had your hand up. Do you have a question or comment for Jeff?
Yeah, just Jeff, to recognize the hand service at UW, your leadership. These are really hard cases, but I think there's a really important teaching point. I mean, you, Doug Hanold, Nick Vetter, your whole team are incredibly skilled. And I think the teaching point, the adage, the enemy of good is better. And at what point with a very difficult case, I think one of the principles here, and we saw it with Chris Peterson's case and Stephanie's case, is define what the end point is, sort of what's the best you can do. And sometimes good is good enough. The enemy of good is better, and we can get sidetracked. And then, the tourniquet time goes on. The patient may be a polytrauma patient. You know this at UW with your catchment area. And you got to do, even in the more definitive environment, damage control. We're going to do some good stabilization. The AO slant is to make everything anatomic and perfect. But at a certain point, you have great looking x-rays and destroyed soft tissue, or, tendons that have been violated. So I could go on, but I'm just so impressed, though, over the years, the incredible work that goes on at Harborview and with you and Nick and historically Jason Coe and the whole group and Doug Hanold out there. And I just want the audience to understand, and I credit Bobak for putting this together. These are Dr. Friedrich's incredibly accomplished. And when all of us share our trials and tribulations, again, that's the best learning. I had a take back a week or so ago that we fixed on a free flap, and the fellows hadn't seen many takebacks. And I said, welcome to learning from things that go wrong and that are bad. And I just had to say that tonight because I've known you so long, but this is a really incredible case. And right at the end of the day, despite what the health of carpus looks like, the patient has a functional extremity. So I'll leave it at that.
Well, I appreciate that, Scott. Thanks for your kind words, and I'm glad this is being recorded. I'm going to send that to my mom. So.
So the last kind of question I have is actually both for you and actually for Stephanie as well, because obviously we're talking about bridges burned, and I think oftentimes we see cases that are sent to us either from other folks within our institution or from folks outside our institution, and these are valuable referral streams, obviously, and you don't want to burn that bridge. Speaking of bridges burned, so the question I want to ask is that of feedback. So when someone sends you a case where something clearly was mismanaged or just not managed in the best way possible, or it was a flat out complication like a entrapped nerve, for example, that wasn't recognized and so on. What is the role of feedback? How do you do that? Do you even do it? Do you bother to do it? I know I myself as a surgeon would want to know if I did something that, caused an adverse event or, I could have done better. It's a tricky area. So I want to kind of get both your perspectives on how you handle that. Maybe Jeff, we can start with you. Okay, Stephanie, let's start with you.
Thank you. I think that's a great question, and certainly a developing skill, right? But I do try to reach out to the surgeon and have a direct, like, over the phone conversation with them, and just tell them what I found, what my opinion was, and usually they kind of know already that something wasn't right, or and I found it to be a useful conversation on both ends, and I think beneficial learning for both people, but certainly with tact. And I think there's many different approaches from the patient standpoint of how much to say to the patient and what approach to take with them. And but as far as talking to the referring provider, I think a direct phone call is best whenever possible, and just being open and honest, but not accusatory. And we all have things that go wrong or unexpected issues that come up, and just trying to take it from a learning perspective for things to do different going forward.
Yeah, I think those are great points. And to your point, I think they usually know, obviously, if especially if something went wrong, right? And they usually do want to hear about kind of what you found. Some of the trickier areas are, for example, Jeff's case. This guy comes from a couple of states over, right? And they probably thought they did a decent job. They say, we got the fixation. All you need now is just a flap, right? So that's kind of a little bit trickier. Like, do you go out of your way to call them back, or do you just say, hey, I got an update on the patient. We ended up doing this because this and that and whatever. What are your thoughts on that?
Yeah, I tend to stick to I don't remember the old show, but it was, just the facts, ma'am. Just providing the facts. And it's, listen, and I'm as guilty as anybody, but it's really easy to editorialize, particularly when you're slogging through one of these cases in the middle of the night and going, God, they can't even, they couldn't put an X fix on right. They couldn't put this on right. But I have to remember that, a lot of times these people are sending patients to me with considerably less people and material resources than what I have in terms of the support. And a lot of times, when they're out in rural Alaska and rural Montana, they're doing the best they can, and they're probably scared, because these can be pretty daunting cases. And so I remember that. I try to remember the battles that the other people are fighting. Provide just factual feedback about what was done, and not personalize it, because I think for the most part everybody's really trying hard, even though we can get kind of grumbly about some of these referrals or dumps that we get sent.
Yeah, and that's a great point. I think it's important to know that folks are trying their best, and that's kind of why it's a bit of a fine line, and oftentimes, as Stephanie mentioned, the patient asks you, right? Did they mess this up? Why did I need to have this other operation? I thought they already did that. And that's when I just, personally, I just say, yeah, you know what, stuff happens, and people have different ways of doing things. I'm not saying it was the wrong way. It's just, unfortunately, this happened, and we got to take care of it. So kind of being kind of neutral and not really saying much more beyond that. Scott, I see you've turned your mic back on. I'm assuming you have a comment maybe?
No, sorry. I'm just
no,
listening.
never mind. Okay, great. Anyway, so we're actually exactly at an hour and a half, which is the amount of time that we had. So I want to thank all of our panelists for fantastic presentations and for taking time, especially on the East Coast out of your nighttime, to be here with us. I want to thank Ilya Cooper and Sonu Jain for organizing the webinar. I want to thank all of our listeners for logging on. And until the next webinar, I don't know when it is, but you'll get an email about it for sure. Thanks, everyone. Have a great night. Appreciate it.
Thanks, Bob.
Thank you.